Just bear with me. If you want to take a nap, I won't hold it against you. Go ahead. Can I take a chair? Okay, so HIPAA, which stands for the American Health Insurance Portability and Accountability Act of 1996, is a set of rules to be followed by doctors, hospitals, and other healthcare providers. HIPAA helps to ensure that all medical records, medical billing, patient accounts meet certain consistent standards with regard to documentation, handling, and privacy. The new things for 2019, any healthcare provider that electronically stores, processes, or transmits medical records, medical claims, or certifications must comply with HIPAA regulations, which everybody's been doing since '96, so not sure why they're considering that new, but and that all patients are able to access their own medical records, correct errors, which is a big push towards the patient portal, and everybody be able to see their stuff. So HIPAA laws and regulations are divided into 5 rules: privacy, security, transactions, identifiers, enforcements, and high-tech act. HIPAA privacy rule is located there, because nobody really cares. The privacy rule established national standards to protect individual medical records and other personal health information. The privacy rule applies to health plans, healthcare clearinghouses, and healthcare providers that conduct healthcare transactions electronically. The privacy rule requires appropriate safeguards to protect the privacy of personal health information and sets limits and conditions on the uses and disclosures that may be made of such information without patient authorization. The privacy rule also gives patient rights over their health information, including rights to examine and obtain a copy of their health records and to request corrections. So if they show up here to the lab or wherever they want their information, they have the right to do that. We just request that they go to MedRecords and sign the form and get it that way, and that we don't give it to them. That way we have a record that they signed it out and that's how they received it. The following HIPAA forms are associated with the privacy rule that they need to be given to the patients. You can find them on the internet. The security rules and compliance addresses the privacy protection of electronic PHI. Similar to the privacy rule, the security rule also deals with identifiable health information as defined by the 18 identifiers. The security rule defines standards, procedures, and methods for protecting electronic PHI with intention to have PHI stored, accessed, transmitted, and audited. The HIPAA security rule addresses 3 aspects of security: administrative, physical safeguards, and technical safeguards. Covered entities need to perform a risk analysis and utilize risk management methodologies so vulnerabilities and possible risks can be reduced. Organizations should assign a security analyst or officer who is responsible or maintaining and enforcing the HIPAA standards within the organization. We do ours yearly, and we've been working on that the last couple of months. So. Hardware, software, and transmission security. Organizations should have a hardware firewall in place. Transmission of personal information should be encrypted and comply with HIPAA rules. Operation systems should be hardened and up to date. Policies should cover the updating of hardware, firmware, operating systems, and applications. Disaster backup and recovery plan policies and procedures should include a disaster backup and recovery plan to ensure the businesses can continue to operate in the event of a disaster. This includes keeping the businesses running, recovering lost data, testing of backup procedures, and replacement of equipment. Policies and procedures should be implemented to induce instant response. This information should be used to identify security incidents and how to respond. The security officer for the organization, along with management, should evaluate the effects of any incidents. Documentation of any incidents should be made along with the outcomes of possible modifiers of the policies for any further incidents. So who knows what you do if HIPAA is breached?
Tell Lincoln.
Yay. Yes, so you let me know. I have 5 business days to investigate, find out if it was really breached or if it was just a misunderstanding, whatever. And then I have to report back to the people involved. And then Rita and I have to, if it's big enough, send it into the state and let them know. But luckily, we've only had to do that once. So organizations should provide a training program to raise awareness. This is where you all are at. And every individual in the organization must be trained on a regular basis. So we do ours yearly. And those are the things that we go over. Policies should define rules on who can have what access to programs and information. These policies should further define the rules and information technology of the IT personnel should have the rights to modify the access. So while we're talking about this, with all the updates and everything that goes through on Centrique, Sometimes things are missed and you're given securities that you should not be given. If that happens, you need to notify your manager as soon as possible and get those off of your Centric login. Does everybody understand what I'm talking about? You know, when you log in, there's all those little boxes that say what you can and get into. If you happen to log in and you notice more than you should, you need to notify somebody right away. And if you access those knowing that you're not supposed to, that you're in violation of our policies. So you can be wrote up and action can be taken against you. So the best thing is if you see something that you know you're not supposed to be in, just get rid of it. You don't have to tempt yourself, you know. It's not there, you don't have to worry about it. Auditing mechanisms should be in place for all hardware, software, and data control, and we do audit. Miranda and I audit everybody's Centric access so we can see what you're in, when you're in it, how long you're in it, and if you're in something that we feel you shouldn't be in, we investigate, report to your boss, and we go from there. Per HIPAA regulation, a code set is any set of codes used for encoding data elements, medical terms, medical concepts, diagnosis. So everybody's aware of ICD-10 and 9 and all that stuff, so I'm not going to go over that. The security of the Department of Health and Human Services had adopted accredited standards, X12 version, whatever. So by January 16th, next month, this new rule is going to be out. And they're not really exactly sure on what all of it's going to entail, just they're really cracking down on HIPAA stuff. So you have to have a unique identifiers, which are medical record number is one, NPI. So it's a unique 10-digit number used for covered health care providers. So every doctor has an NPI number that only they have. We have, sorry, I'm very scattered right now. I came right from the ER here, so my mind is going in another direction. Anyways, next slide. The HIPAA enforcement rule stems directly from High-Tech Act provisions that distinguish between violations occurring before and or after February 18th with respect to the potential amount of civil money penalties and the defense available to covered entities according to the rules. So my investigation of this is that if there's violations that happened prior to February 18th, they're going to go off the old rules, and anything that happens after will go off the new rules because they're so far behind on prosecuting and investigating HIPAA violations that's why they put in a date to have it be a deadline. So High-Tech Act addresses 5 main areas, and it works alongside the HIPAA rules. So it applies the same privacy and security requirements as HIPAA, establishes mandatory federal privacy and security breach reporting requirements, which is what I said earlier, if the breach is big enough for Rita and I have to report it to the state and the government. Creates new privacy requirements for HIPAA entities and businesses, and it talks about the penalties for violation of those things. Okay.
Julie, thank goodness you're here.
What's wrong?
My phone's running slow, and now I have some strange app installed.
Really? You do anything out of the ordinary?
I got a text saying my chat app needed an update, so I used the link they sent me to update it.
Do you normally use links and text messages to update your apps?
Well, no.
I'm starting to see the problem. Wait, you're logged into the company's Wi-Fi, aren't you? We need to get on this right away.
Have no fear. I'm here to help.
Captain Awareness!
Nick, why the long face? Nick the Click strikes again.
I think I've infected my phone with some type of malware, and maybe the company's network.
I'll take care of it. First things first. Call IT and report what happened. They may have some damage control to do. I didn't even know I could do that. 1 second. There you go. The malware is gone from your device.
My hero.
Remember, never trust an unexpected text or email that asks you to download an attachment.
And never download an app through a link in a text message.
Yeah, don't be like Nick.
Hey,
Also, protect yourself further by encrypting the data on your device and applying regular system updates.
Oh, and only download and install apps from trustworthy sources.
Exactly. Nick, be more like Julie.
Thanks, Captain Awareness.
Yeah, thanks.
Follow those tips. They'll save your data and protect your network.
Sorry, I thought that was cute. Sorry, I didn't almost say it. Hold on. Did it go? Heather, see what happens when we're prepared.
All right.
Oh, just wash.
Oh, no.
Thank you.
Hold the elevator, please.
Morning, Nick. How's it going?
I'm running late for a meeting. If I give you my security code, can you bring the Mitnick files to the conference room?
Absolutely not.
Okay.
Remember the training we had about being a human firewall?
Yeah. Don't click on suspicious links or open unexpected attachments. What does that have to do with the Mitnick files? Captain Awareness, you use the elevator?
Yes, and stairs from time to time. It's in the superhero agreement.
There's a superhero agreement?
Never mind. What's important here is that you know how to be a human firewall.
I was just telling Nick why he can't give me his security code.
That's wise advice. Never share your passwords, pins, or codes. Also, don't forget about physical security measures like locking your computer and looking out for people trying to gain unauthorized access by tailgating.
Oh, I guess I can see why those things are important security measures.
This is our floor. See you later, Captain Awareness.
But I was going to get a cinnamon swirl donut from the break room.
I'm sorry, but you'll need to sign in at reception first.
Now you're catching on, Nick. Human firewalls always follow policy in regard to visitors. Now about that donut.
Seriously, sign in at reception.
Tough crowd. Until next time, this is Captain Awareness, reminding you to keep security awareness top of mind.
Okay. Alright, those were just some cute little videos that I found.
Don't close that. Don't close that.
Don't close it?
No.
Okay. Okay, so does anybody have any questions? I know that was a very fast overview of HIPAA. The main thing is, don't talk about stuff that you know you shouldn't talk about. Don't get into things that you know you shouldn't get into. You know, I guess my opinion on HIPAA is mostly it's common sense stuff, you know. But does anybody have any questions? I can try my best to answer. No? Thank you all. Merry Christmas to me, no questions.
Everybody gets seated. Okay, infection prevention training. We have two types of definitions of infection. There's a community acquired. That means like I come in here and I see Carrie and I have pneumonia, so she puts me in. It's a disease or an illness that I have gotten outside of the facility. Then there's nosocomial, and that's the one we don't want. That's the one that if I came in with, I don't know, say a UTI, and on the third day I'm starting to cough, I've got a temp, and my lung sounds are bad, and I've got pneumonia. And that's something that I acquired in here, and so it's a nosocomial infection. In American hospitals alone, CDC estimates that hospital-acquired infections account for an estimated 1.7 million infections and 99,000 associated deaths each year. And of these infections, they divided them out into like surgical and some of the others, and the highest percent went to UTIs or COTIs, that after the patient came in and a Foley catheter was inserted, they got a UTI from within the facility. CDC says hand hygiene is still #1 way to help prevent the spread of infection. Use the right amount of alcohol-based hand sanitizer, and the efficacy of the hand sanitizer depends on the amount applied to the hands. When you use the hand sanitizer, you want to be sure and get in between your fingers, around your nails, and under any jewelry. That seems to be where the germs hide. And it's just getting into a rhythm or getting into a habit. We have plenty of the hand sanitizer machines around the facility. I also have the small ones that any of you are welcome to. I also have ones that are the squirters, and you can put them on a zip line. I know a lot of the employees that work patient hall, they use those. There's one right by the time clock. If you get into the habit of coming in every morning to sign in or sign out, and you use that, it's just the habit of getting into it. Cover your cough. They still say cover like this. Put your cough into the bend of your elbow. Don't cough and have it fly all over the place. Stay home if you're sick. You must be fever-free for 24 hours, and that's without taking Tylenol or ibuprofen to help bring your fever down. If you're absent for 3 consecutive days, you need to see a provider for a note to return that is safe for you to return and be around the coworkers and the patients. And then also the employee health form that I have. If you're out for some reason, because you're contagious and you could give it to somebody else, then please see me. State requires that we track employees. Not that I give any information to state, but it's like, say 1 o'clock, 5 people went home and they're all vomiting, but they all ate here, or we had a buffet, or we had a potluck. It's just to track so that we can stop. If it's something like the lettuce in the kitchen, if they've got a bad batch or whatever, if it's something that somebody brought, then we need to track that and make sure that more employees aren't exposed to it. And when state comes, they say, how do you track your employees? I just pull the book out with all of them that you guys have given them. They see that I've got a book, they see that there's something in it, and that's what it's about. Influenza, all employees received the flu vaccine this year. As of December 1st, CDC reported that 5 children have died from the flu this season. Last year was one of the deadliest, and 80,000 people died and 180 were children. So far this season, we've only had 3 positive tests confirmed by a test, and they've come from the clinic, and they've all been the type A, and it's pretty much age 45 and a 36-year-old. And Nebraska is reporting 2 deaths from the flu this season so far. Tuberculosis, I know you're wondering why are we talking about tuberculosis, but this is something that state requires to be in the annual training. There's 2 types of first of all, tuberculosis is an airborne disease. There's 2 types. There's latent, and that's when you have a small amount of TB that's active in your system, but your body's handling it and shutting it down. That's when you have it in your inside, but you can't spread it. Active, that's when it's contagious and you can pass it on. And I've noticed a lot, there has been some big TB outbreaks in other states, and a lot of times it's where there's so many homeless, and it starts down in the little homeless village. Nebraska had a total of 21 active cases in 2017, and this was down from 2016. We did not have any in Dundy County. Most of them are clear back east along kind of the border. Any TB patient that we would have, they would be kept in the scope room, which is a negative air pressure room, and then they would be transferred to Kearney or Denver, where they're more equipped to handle. Bloodborne pathogens. OSHA definition is disease-causing microorganisms found in human blood, as well as human blood components and products, saliva, tissue, vaginal secretions, and semen. There's 3 major pathogens: HIV, hepatitis B, and hepatitis C. Transmission of these: contaminated sharps or needle sticks, non-intact skin, acne, cuts, scratches, and contact mucous membranes found in the eyes, nose, and mouth. And there is a lot of new cases of HIV and hepatitis B and C, and it's in states where the opioid crisis is so bad, and they're sharing the needles. And in some, it's become such a problem. I know lately I've heard in Denver they want to open a center where
Safe injections.
Yes, where the addicts can go and safely inject their opioids or their heroin or whatever, because there's so many deaths and overdoses. So I mean, it just doesn't make sense to me. But we can't get a handle on helping, and so I guess we enable.
There's that, yeah.
Treat all bodily fluids as if they were infected. Use standard precautions. Choose PPE according to potential exposure. We have spill kits. They're located in dirty workroom. The lab has one at the bottom of the basement stairs. Stratton Clinic, Quality Health Care, and the supply closet near Patient Hall, the one over there in the corner. And each of the kits is specific to the area. Wendy wants us to be sure, and if we have a blood anywhere, she would like to know right away so that housekeeping can properly take care of it. Eye wash stations, there's one in the dirty workroom, 2 in the clinic, 2 in the kitchen, housekeeping closet, bathroom in the basement, pharmacy, lab, ER, and the boiler room. And we have had 1 needle stick is all this year. We have had no hospital-acquired infections this year. I track like inpatients, like acute patients, observation patients, and track their cultures to the end so that I can give them to the providers as they come down so that we can get the people on the right antibiotic or make sure that they are on the right antibiotic. We had 239 patients from January to November, and we had 239 cultures that I followed. Hand hygiene, our compliance through the 3rd quarter was 89%. We participate in the ILI surveillance report, and I do that weekly, and I keep track of how many patients we've had through the week. It also asks, are we, a lot of our employees, are we short because of the flu going on here? And then that gets forwarded to Melissa Propp at Southwest Public Health, and then she gathers from her district and sends it on to CDC, and this is how CDC knows which states have the flu going on. And I think Karen, our lab, reports how many of the positive flus and stuff that they have also. We also participate in the Nebraska Hospital Association, the COTI program, and hospital-acquired C. diff and MRSA, and I believe Miranda reports this. Antimicrobial stewardship, it's a coordinated program that promotes the appropriate use of antimicrobials, including antibiotics. It improves patient outcomes, it reduces resistance, and decreases the spread of infections caused by multi-drug resistant organisms. And this is a real problem nowadays because the bugs are growing bigger and stronger, and the output of new antibiotics to fight them, the drug companies are not coming up with any new antibiotics. At least 2 million illnesses and 23,000 deaths are caused by antibiotic-resistant bacteria in the United States alone. We were lucky enough that we participated, the Nebraska Department of Health and Human Services Office of Public Health and the Office of Rural Health, they received a grant providing a number of the rural critical access hospitals with assistance with antibiotic stewardship. And we're accepted to participate in this. And the program, there's a Dr. Horn and another doctor in his group, and also a pediatric infection doc who is available to our providers 24/7. And they can call them anytime when they have a question on anything. I mean, like, okay, I've got this patient that grew out this, what do you suggest we put them on? Or I've got this patient on this for pneumonia, how many days do you think they need the IV before they're switched to oral? Or which antibiotic do you think is appropriate? They usually try to do like a less potent antibiotic if it's susceptible to that, instead of hitting them with a big gun. Try to save the big guns for the more resistant bugs. And so this has been really, really nice. It's been very helpful. And you know, some of the bigger hospitals have their infection docs on staff, like North Platte has one, and it's so nice for them because they're on staff. But the smaller hospitals, the critical access hospitals, don't have this offering. So this grant is good for a year. It was started last May or June, and I'm hoping that they renew the grant again and that we can stay in the program. It's nice for the patients and it's nice for our providers. How you can help: take antibiotics exactly as your provider instructs. Only take antibiotics prescribed to you. Don't save the antibiotics for the next illness or share with others. Don't pressure your provider for antibiotics. And most important, and one we can all do to prevent infections, is the hand washing and basic hygiene prevent infections occurring and reduces the transfer of infection. The antimicrobial stewardship does not mean, no, by God, you're not going to have any antibiotics. Nobody gets antibiotics anymore. It's just giving them to someone that really needs them. I mean, if I go in and I've wiped my nose 3 times today and I go in and I say, I want an antibiotic for this nose, it's been running, and there's no need for the antibiotic for my nose running. And so the provider does a very good job of assessing you and knowing if you need an antibiotic or not. And so sometimes it's a concept of antimicrobial stewardship is, well, I don't want to participate in that because you're not going to get an antibiotic for anything. No, it's just the careful selection, putting a patient on the right antibiotic, giving the patient an antibiotic when they truly need one. Now I have a doning and doffing from the Med Center. It's just a YouTube, and that is part of the state also, to show proper doning and doffing. Any questions so far? And this is
Personal
from the
protective equipment should be selected based upon
the
proximity to
University
the
Med
patient
Center in
and the
Omaha.
likelihood of
And they put
contact with
this
any blood
together
or body
when
fluids
Ebola
during procedures in the
was-
patient care area. This video will demonstrate the proper sequence for donning and doffing personal protective equipment from the Centers for Disease Control. The first step in donning personal protective equipment is good hand hygiene. The second step of the procedure is donning the gown. The gown should be fastened at the back of the neck and the waist by tying a bow. The third step is the selection of respiratory protection. One option might be a procedure mask. Procedure masks are used for droplet precautions. Droplet precautions are used in the care of patients with influenza. To apply this mask, gently crease the metal insert to create an indentation for your nose. Then cuff the elastic bands around your ears and spread the mask to cover your face from the bridge of your nose to below the chin. Finally, ensure the mask is snug and comfortable on your face. Procedure masks also come with attached eye protection. This mask is applied in a similar fashion. Respirators act as a filter to prevent small particles from entering the airway of the person wearing them. A respirator should be fit tested annually in order to ensure a good seal. The properly sized respirator should always be used. Place the respirator on your face and position the straps at the back of the head and at the base of the neck. The elastic straps should be in contact with the skin on your neck, so remove any hair that is in the way. Press the mask along the edges to seal it to your skin. Finally, breathe deeply in and out, feeling for any areas where air may be escaping along the edges. Respirators can be shaped to fit the face or be folded. Folded respirators are applied in a similar fashion, ensuring that the respirator is fully unfolded and has a tight seal with the skin. Again, breathe deeply in and out, feeling for any areas where air may be escaping along the edges. Facial hair will prevent the respirator from making a tight seal with the skin. Even a small amount of stubble will compromise the seal and reduce the protection provided by a respirator. If the respiratory protection you selected does not have attached eye protection, eyewear should be selected next. Protective eyewear might be safety glasses or goggles. Many shapes and styles are available. The final step in the procedure is the application of gloves. Ensure that the cuff of each glove covers the wrist of the isolation gown. Before entering the room, ensure all personal protective equipment is in place and comfortable. This will prevent you from adjusting your personal protective equipment while in the patient care area and potentially contaminating unprotected areas of your body. You are now ready to provide care to your patient. The first step in the procedure to remove personal protective equipment is doffing the gloves. Gloves are removed first because they are likely the dirtiest item and are contaminated on the external surfaces. Grasp the first glove on the external surface at the cuff and gently peel off. Hold the removed glove in the gloved hand. Then slide a finger of the ungloved hand under the remaining glove, touching its clean side only, and gently peel the second glove off over the first glove. Discard the gloves in the trash. All movements in doffing should be slow and intentional to prevent the aerosolizing of any contaminant on the used equipment. The second step in this procedure is to remove your eye protection. The glasses or goggles are contaminated on the outside, so touch only the earpieces or elastic bands while removing them. Eye protection should be placed in the trash or be placed in a designated area for reprocessing. The third item to be removed is the gown. The most contaminated areas of the gown are the front and sleeves. Unfasten the ties at the neck and waist, then remove the gown by slowly pulling it down and rolling it away from the body with the clean side out to form a bundle. Use the foot pedal to lift the lid on a linen hamper. Then place the entire gown inside the bag. Disposable gowns may be discarded in the trash. Be sure that the entire gown is inside the trash can. Gowns left hanging are a risk for contamination. The fourth step is the removal of respiratory protection. It is removed last to prevent any transmission of contaminated particles to your respiratory tract while removing the other equipment. Touching the front of the mask or respirator should be minimized during removal. When a mask or respirator has two elastic bands, remove the bottom one first. Discard the mask in the trash. Finally, perform good hand hygiene immediately after removing all of your personal protective equipment.
Any questions on PPE? The one thing I wanted to point out was, did you notice that before they put the gloves on, you use your hand sanitizer? Sometimes the idea is, oh, well, I don't have to use it because I'm going to put the gloves on and the gloves are going to take care of it. Well, how many times have you gone to put a pair of gloves on and there's like a rips or there's teeny tiny holes that we may not know is there? And you're in the middle of cleaning up someone with C. diff or something that's bloody, and that's going to go through and get on your fingers and your hands. The same way with when they were done, they took the gloves off. Use your hand sanitizer in case there is something in there. The other thing I just want to say is, it's not just one person's job or two persons' job for infection prevention. It takes everybody. I mean, I can do whatever I think as far as hand hygiene or whatever, but if the next person comes along and they don't, so it just takes everybody. And thank you. Any questions? Okay. Thank you. Thank you, Heather.
Email them or write them down and they will get back to your answer. So let's watch this quick little 5-minute video.
We live in a world of chemicals. Our bodies produce and use chemicals. Plants and trees produce them. Even water is a chemical compound. Other chemicals in our world are man-made synthetic compounds. Although we don't know exactly how many man-made chemicals are in use today, experts generally agree it could be more than 100,000. Gasoline, paints, household cleaners, detergents, toiletries, wipes, solvents, everyday products used at home or work are made of chemicals. Before using any chemical product, you should find out all you can about it, and this information is literally at your fingertips in free publications called Safety Data Sheets, or SDSs. OSHA's Hazard Communication Standard requires chemical manufacturers, distributors, or importers to provide safety data sheets, formerly known as Material Safety Data Sheets, or MSDSs, to communicate the hazards of chemical products. All safety data sheets are required to follow a specific format and provide detailed information in 16 different sections. To protect yourself, your coworkers, and your family members, here are the top 10 things you should look for on a product's safety data sheet. What is the emergency phone number? If someone is injured, hurt, falls ill, or poisoned by a chemical product, who would we call to get more information? You can be sure emergency medical personnel, especially physicians and nurses, will want to see the safety data sheet. The manufacturer or distributor's name, address, and phone number is required to be right up front in Section 1, along with 24/7 emergency phone numbers. What is this product recommended for, and are there any restrictions on its use? This information is also required to be included in Section 1. How dangerous is this product? Statements like causes irreversible eye damage, highly flammable, and can cause central nervous system damage appear on safety data sheets even for seemingly harmless everyday household products. Section 2 is called Hazards Identification, and it is required to include all hazards regarding the chemical. What do you do if the product gets in your eyes, on your skin? What if you inhale or swallow some? Section 4, First Aid Measures, lists the signs and symptoms of exposure to the chemicals and whether the effects are usually immediate or delayed, and the appropriate first aid measures to take. If the product is accidentally spilled or otherwise released from its container, how do we clean it up? What materials can we use, and how do we dispose of everything properly? Should we wear masks or gloves? Eye protection? All this should be listed under Section 6, Accidental Release Measures. Are there any specific cautions we should be aware of to make sure we are safely handling and storing the containers of this product? Is it dangerous to store in certain places or near other chemicals or products? Does it have to be in a temperature-controlled environment? Section 7, Handling and Storage, provides this information. When using this product, what personal protective equipment should we be using? Should we use special gloves, splash goggles, or protective clothing? What should we do to prevent exposure to any hazardous chemicals in the product? Will we need to provide extra ventilation? Section 8, Exposure Controls, Personal Protection, tells us what we need to do to engineer a safe environment when using the chemical. What does the product look like? What color is it? Does it have a distinctive odor? Are the vapors heavier or lighter than air? At what temperature will it ignite? Is it an acid or alkali? Section 9, Physical and Chemical Properties, lists the chemical characteristics we should know. What other materials should never be mixed with this product? Can it become unstable if exposed to heat, light, or anything else? Could this product react with other materials like metals, causing it to decompose into a dangerous, hazardous chemical? Some chemicals, when combined with certain others, can cause an explosion or fire. Section 10, Stability and Reactivity, outlines these cautions along with any known hazardous reactions. One of the most important sections of the SDS is Section 11, Toxicological Information. Could repeated exposures to this product cause allergic reactions? Are there any short or long-term health effects to exposure? Is this product associated with birth defects? Can exposure cause genetic mutations? Can it affect reproductive organs or the development of a fetus? By what routes can this chemical enter our bodies? And is anything in this product known to promote or cause cancers? Section 11 outlines this important information. When working with chemicals, we can never have enough information. Get the safety data sheets and read them thoroughly. Protect yourself, your coworkers, and your family.
Okay, I got several things I'm going over. I'm going over tornado, over the fire safety, gonna throw in a little bit of emergency preparedness, and some winter weather. I'm gonna start with the tornado. So, does everybody know the difference between a tornado watch and a tornado warning?
Watch's conditions are favorable. Warning is one's been spotted.
Yeah. In a watch, conditions are favorable for them to form. A warning means there's either been one spotted by a trained weather spotter, it's been seen on radar, or it can form without warning. So In a tornado watch, what we do here is we put out our sign-in sheet. You go to the nurse's station, you sign that you're here. If you leave the facility, you sign yourself out, or you let the ward clerk know at least so she can sign you out. When you come back, sign yourself back in. That sheet right there is if we would happen to get hit by a tornado, what the responders are going to use to search for people that are missing. So we don't want to waste a bunch of time looking for somebody that's not actually here. At that time, any equipment that you're not using, you want to tuck it away and close the blinds on all the windows. You kind of want to get ready so if it does turn into a warning, you can quickly do our warning protocol, which is everyone comes to the safe area between the fire doors out here around the nurse's station. The sheriff's office will call up here when a warning's been put out. They'll let us know that it's going on, so we'll get everybody to the safe area. We cannot hold people against their will. We can advise them they shouldn't leave, but if they want to leave, we have to let them. On the same notion, you don't want to keep anybody out. That's why we don't lock the door when we're in a warning, because if somebody going down the highway needs to get to a safe place, they can come in. So that's why that door doesn't get locked in that. A little bit on the summertime weather. I just got some facts here. A severe thunderstorm watch is issued when severe thunderstorms are possible or in the near future may reach your area. It doesn't mean that they'll occur. I mean, it's weather. It might be 3 miles that way. It might actually be your area. Who knows? And the criteria for a severe thunderstorm warning or watch is they're predicting winds of 58 miles per hour or higher, and or hail up to 1 inch in diameter or larger. So if it is a warning, you're going to have 58-mile-an-hour winds or the possibility of hail 1 inch in diameter or larger. That's what they're looking at on that criteria. In the wintertime, you have a few different kinds of watches and warnings. The winter storm watch is issued when there's a potential for significant and hazardous weather within 48 hours. So they'll never be issued longer than 48 hours. I know sometimes it seems like it's a week, but when they actually issue that, it's never longer than 48 hours. So what they're predicting is 5 inches or more of snow within 12 hours, or 7 inches within 24 hours, or enough ice accumulation to cause damage to trees and power lines. The snow sleet criteria for a winter storm watch for the 5 westernmost counties is 6 inches or more within a 12-hour period. A blizzard warning means the following conditions are occurring or expected to occur. So for a blizzard, it's going to be a 12 to 18 hour forecast. It's going to be snow or blowing snow, which reduces visibility to a quarter mile or less. That is their criteria for a blizzard warning, is basically the visibility. And then the winter storm warnings, they're the same as the watches, it's just when it's happening. So around here on our winter weather, we try to get everything cleaned as fast as we can. I want you guys to remember, when you get out of your cars, get to the sidewalk as quick as you can. A lot of people like to cut across the parking lot. That's the most dangerous place you can be. We got the loader running, and as soon as we uncover that, that turns to ice. You're safer on that sidewalk. Even if it's covered with snow, you have better traction than you have on that icy parking lot. So always try to get to the sidewalk as quick as you can. So we try to get it off of there as best we can. I know the last couple of years the parking lot across the street has been a challenge, but I can't scrape it down or I'm going to cause worse problems than we have already over there. It's just gonna cause more holes, so. The plan is this spring they're gonna get some millings and they're gonna reface that parking lot, so. We may have to put up with it for a while, but it's gonna get fixed, so. Just letting everybody know that. Any questions on weather stuff? I'm gonna go pretty
Hey
fast.
Vince, what's this new thing I saw this winter? A significant weather event. Do you know what that is?
It's a little bit different than some of the other stuff. Let me see if they talk about it. I don't have it on here. Basically, it's something that doesn't reach blizzard or winter storm warning criteria, but it can still be in certain areas. You can have an ice buildup, lose power, have slick roads, things of that nature, but it doesn't meet the specific requirements of a winter storm or a blizzard warning. So that's what that is. Any other questions on weather? Okay. The next one I'll go over is fire. When we have a fire drill here, this is what you're looking for. It's just a box, got a flashing red light on it. It'll be somewhere in the hospital. When I activate them myself, I put that in an area and then I either pull the alarm or I take a smoke detector out, whatever it takes to set the alarm off for that area. Then everyone seeks that box. When you find it, you want a page overhead that the fire is all clear. That way everybody knows they can quit looking. A lot of times the question is, once I check my area, can I go through a fire door? Yes, you can. As long as you look through the window, you don't see smoke or fire, you feel it with the back of your hand and it's not hot, you can reach that fire door to keep seeking the fire. We have fire extinguishers here. You don't have to use them. You can grab one if you want to. We use RACE, and our E stands for evacuate, not extinguish. The size fire extinguishers we have right now here would put out that trash can if it was on fire. They're not a big area fire extinguisher, so don't feel like you have to put that fire out. If it's in a patient room, get the patient out of there, shut the door. If you have other patients, you need to evacuate them outside, and you will evacuate them in an order to which your nearest immobile person will be evacuated first. If they can walk themselves, you can have them go with you. But if you have somebody across the hall that's immobile and you have somebody in the room right next to them on the same side of the hall, you want to evacuate the one on the same side of the hall first. You always want to do that. So does anybody know what the rest of the acronym RACE stands for?
Rescue, alarm, combining, and extinguish, or evacuate.
Yep. Evacuate. The way our hospital is set up with our fire doors, each one of those fire doors, where that fire door is, and the way the bulkhead of the walls are built, that's a 2-hour fire and smoke separation from the next part of the building. So theoretically, that shouldn't burn through that or get smoke through it within the first 2 hours. Our doors, our ceilings, and our walls are all 1-hour fire rated. So if there was a fire in this room right here, you shut that door and you shut that door, no fire should get out of this room for an hour. Not saying it wouldn't, but the professionals say it won't. So there is time when you have a fire. Main thing is keep calm, do things the right way. You've probably noticed in the last couple of years I've done fire drills sometimes in a different manner. The fire marshal wanted us to do that because most of the time in the event of a real fire, your alarms aren't going to go off. Somebody's going to walk in that room and they're going to find it. So what you want to do is, as soon as you find that, you want to first get that person to safety. Second, go to your nearest pull station. They're at every exit. Pull that alarm. That's what's going to set off the alarms, and everybody's going to know that there's a fire. And the reason you want to go to the nearest one to where you're at is because when it comes up on the panel, you don't want to have a fire down patient hall, but you pulled the one back by x-ray because everybody's going to go that way looking for the fire. So always remember to pull the one nearest to you. So sometimes what I'll do is I may put somebody in the bed, I may not. I'll put that in the room and I'll just pull the call light. When you walk in and you see that, you should immediately initiate fire protocol. Whether it be getting the bed out of there if somebody's on there, or if there's not, simply going to the pull station, pulling it and activating the fire drill. The fire marshal did tell me he had a guy in a nursing home. He took it to another level altogether, and he put a fog machine in the room. So when the nurse opened the door, she actually thought it was on fire. She ran out of the building. Left the door open. When somebody else noticed it, they did pull the fire alarm. Fire department showed up, found the smoke machine. Guy lost his job. But it was, I mean, that's as real as you can get. So we won't be doing that here. I've already been told we will not be doing that here. So, when we finish up with this, we'll go out there. I'll show everybody the panel, and we'll go over that for our annual training on that. Does anybody have any thoughts, concerns, comments on fire? Okay. So on emergency preparedness, I just want to talk a little bit about, we're trying to get our decon back up and running with the new decon team. A lot of our people have left. We've gotten through the physicals. So Heidi and I will be putting on a first receiver training that we went and took. We are able to teach first receiver training now. So we will go through that when it's kind of slows down. We got a lot of stuff to get through before the end of the year. But at that point, then we're going to do an actual wet decon with everybody. So we'll set up the tent, we'll go through, run people through the shower, and then from that point, we're going to try to train every quarter from that point on. To date, we haven't had a huge problem with decon, but it only takes one time of not being prepared and you're in trouble. So we want to get that up and going. We did do position-specific training on our emergency operations stuff. If you want to watch that, it is on YouTube. You can watch trainings on incident commander, safety officer, liaison officer. We went through all of those. You can look through that. We went through our plan and we've spiffed it up a little bit, changed some things. There's a copy of it in the mailroom. So anytime you're bored and want some reading, you can read through the emergency operations plan. It'll tell you exactly what our plan is for any incident that we may occur. And if anybody wants trainings on anything to do with that, let me know, and we'll try to get trainings people want to have. I think our last trainings, the people sat through them. They thought they were pretty good, I think. It's kind of a dry subject until it happens, and then you're like, oh man, I should have went for this. We will be having a training yet. We had to postpone it because we weren't going to have enough people around last weekend, but we are still having that. We had our active shooter training here, what was that, a week ago? And we're gonna try to build on that, and I wanna actually have a exercise where we portray an active shooter in the hospital. It's gonna take a lot of planning, because I really don't want somebody not knowing and calling the cops and then I get shot, so. Any questions on any of that? You all look like you got the deer in the headlights look, so I think I'm gonna just go show you the fire panel. I'm done.